This is something new which I am going to discuss with you. A lot has actually changed in recent years in diagnosis and treatment of heart failure with preserved ejection fraction. So let's dive into this. During you understand there is a very large population of the world which is suffering from the heart failure, and the incidence of heart failure is increasing because of the aging population and many other factors. And if you I tell you, this is double the population of Australia, and 50% of the patients of heart failure are actually heart failure with preserved ejection fraction, and the incidence of this is increasing basically because the age is increasing. You have increased epidemic of obesity, diabetes and hypertension, and even CKD is incidence is increasing. So that's the reason once you have these grounds to create heart failure with preserved ejection fraction. This is the recent article on heart failure with the preserved ejection fraction. The consensus statement, and if I am more than age 40, the likelihood of me suffering from heart failure is about 20%, which is very high. And I do understand that there is an increased incidence of heart failure with preserved ejection fraction, while reduced ejection fraction incidence is gradually plateauing or falling. During this talk, I'm going to share lots, and I'm going to tell you about how to diagnose heart failure. Now, the first we should say that what is the definition of heart failure in diastolic with the preserved ejection fraction, and it is diastolic dysfunction is not equivalent to heart failure with preserved ejection fraction. Both are two different entities. Then what do we mean by diastolic dysfunction? It's that if you have an increased LVEDP or increased LA pressure or pulmonary artery wedge pressure at rest, or once you do an exercise or there is an increased volume into the heart, it's unable to do it maintaining the normal LVEDP. Whenever you increase the volume into the LV inflow, the LVEDP rises. Clinically, though, we say that we have to have symptoms of heart failure because of cardiac disorder and with a normal ejection fraction, but you should have one of these also positive, that is, you have an anti-pro-BNP or natriuretic peptides increased, or you should have an objective evidence of pulmonary or systemic congestion. Showing you a case of heart failure with preserved ejection fraction. Look at this 4-chamber view. What you notice here is there is a marked left ventricular hypertrophy more at the apex, and you notice mitral annular calcification, and you notice that RV also is dilated. It's little bigger than LV, and the LA and RA are both dilated. And then you see on a parasternal, you notice there is a mitral annular calcification, some thickening of the aortic valve, and a concentric left ventricular hypertrophy. There is an increased LA size, but there is no mitral regurgitation. There is a mild tricuspid regurgitation, and the regurgitation jet is more than 3 meters per second, which indicates pulmonary artery hypertension. You have an E more than A in LV inflow, and E velocity is little more than 100 centimeters per second. But if you see the E to A ratio, that is the characteristic normal. That's a lateral E to A ratio. So even with this normal E to A ratio, you have patient with the diastolic dysfunction. That was the whole point. And you notice the LA is enlarged. LA is 45 ml per meter square, where the normal should be 34 or less. And that's LA dimensions. The best way to take a measurement is in a 3D heart model, and in this you can also take LV mass, which is also increased. You have LV volume, which is also increased. Quite characteristics of heart failure with preserved ejection fraction. I am going to discuss heart failure with preserved ejection fraction in these subsets. First I will discuss about diastolic heart failure, the pathophysiology. You need to understand, that's why it's important. Then I would discuss that how do you suspect, and then how do you diagnose heart failure with preserved ejection fraction. Then I would tell you that heart failure with preserved ejection fraction is a syndrome. It just does not involve heart, involve so many organs, and many a times it so happens heart actually is normal or mildly abnormal. Because of the increased volume, you would have a problem with the diastolic functions. And then the role of artificial intelligence and some carry home messages. So please be with me right throughout the talk so that I can share with you the recent advances in diastolic heart failure or heart failure with preserved ejection fraction. To pathophysiologically, the diastolic dysfunction is actually first to appear. What happens when you have a systole and a diastole? Now you have a head of the myosin which is attached to the actin, and the release or disengagement of this myosin head requires energy. So diastole is not a passive process, it's an active process. But where does the ATP come from? ATP comes from the T tubules, and these T tubules actually give ATP, and they absorb or take away calcium from the milieu. So very first thing, the very interesting study which was done and showed that these are the microfilaments or T tubules what you see here in the skeleton of the cardiac muscle, and this is after 12 months in a normal or a case control mouse, and you see it is maintained. And if you have hypertension in the mouse, you look at the early microtubular damage which happens, and a late microtubular damage and causing a tubular clumping, and with just hypertension of 17 months. So it is in the same mice, you see if we have hypertension very early on in the 4th month of hypertension, there are changes of microtubules, and as the left ventricular hypertrophy and heart failure sets in, then these microtubules are damaged. The very first thing what happens in systolic and diastolic heart failure is the abnormality in these microtubules, which are important for calcium milieu. Now, how do we suspect heart failure with preserved ejection fraction? Very first thing is that the ejection fraction should be normal. What is normal? Normal what we've been taking in the trial is more than 50%, and less than 50% we say it's a mid-range ejection fraction heart failure or heart failure with reduced ejection fraction. The cutoff is 50. Is that the right cutoff? Population study shows that our normal ejection fraction is not 50 plus. It is 55 in males and 60 in females. So right, you have a higher ejection fraction. We don't use cutoff of 50 in our patients also. Between 50 to 55, we say it's a borderline LV systolic function. So I think the normalcy is also important. What is the ejection fraction? This is what we've been doing, right, quite some time. We have a patient with hypertension who is controlled with a couple of drugs. We have a diabetic, and we have a patient with an ideal kind of a weight, but he is dyspneic. Now, what we would do is that's a usual investigation we would have done. Then we would do a biochemistry to rule out the important factors. We would do a hematology, and we do an X-ray chest, ECG, and we do any echocardiography, including the diastolic functions, and that's what it is. And then we start treatment. But I don't think so. This workup is enough for a patient who has normal ejection fraction and dyspnea. Okay, so what should be done? Now, first thing obviously is you suspect heart failure, and suspicion if ejection fraction more than 50, and you rule out other causes of dyspnea. Fine. So once there's a challenge there that you have a patient who you suspected to have heart failure, preserved ejection fraction, there are comorbidities. Now, you do not know that this dyspnea is caused by heart failure, anemia, or is it an angina equivalent, or there is a CKD which is playing a component of dyspnea. So things are not very simple in a condition where you have multiple comorbidities. And how do we diagnose heart failure with preserved ejection fraction? That is the most important thing which we are going to delve into today. Now, we should do a clinical scoring system, including the diastolic parameters. And what are the diastolic parameters? We have been doing these diastolic parameters, and this is what our main thing had been always been focused on. You have three kind of patterns: normal, pseudo-normal, and restrictive filling pattern, or A more than E, which I am not discussing here. Now, if you have a restricted filling pattern, A ratio more than 2, you say that, okay, this is the diastolic dysfunction for sure. Once you have a normal, a pseudo-normal, then you bring in other parameters. You bring in the annular velocities, which I'm going to show you in the subsequent slide. Average E to E prime, you see the LA volume, and you see the TR velocity. If you have 2 out of 3 or all 3, then you say this is diastolic dysfunction. And these are the lateral E prime. E prime should be more than 10, and medial E prime should be more than 7. And if you take an average of E to E prime of medial and lateral, an average should be less than 14. So these are the 3 parameters these days we use for assessment of diastolic dysfunction. But I mean, is it good to make an assessment based on E prime and E to E ratio? Not too good. You still get a lot of disparities and discordance. Look at in these two boxes, and this wasn't a very recent study. And recently we've seen that there is a significant scatter of, depending upon the age of E prime and E to A ratio, then we cannot make a clear judgment what is normal and what is abnormal. So this isn't a very good parameter, or should not be the only parameter to make an assessment of diastolic dysfunction. So what else can be done? We can do an LA volume, and we can do an LA strain, and these also kind of contribute to our clinical scenario. Just incidentally to tell you, LA's volume is a very important predictor of future cardiovascular morbidity and mortality. And what is that? Let us say if you have a patient who has a CAD, and this is the risk ratio, it's about 2.3. Again, if the patient has low ejection fraction, that's the risk ratio. Look at LA volume. The risk ratio is 9 times. So LA volume out of all is the best predictor of cardiovascular events in future. So how do we apply the clinical parameters for a diastolic assessment? Now, the first thing what we do is that we take the clinical parameters if the person is obese, hypertensive, and these are the points what we give. We look whether atrial fibrillation, look at the 3 points are given for atrial fibrillation. Pulmonary hypertension in case, or you have a patient who is an elderly and elevated filling pressure. Do you notice something here? Let us say if I tell you a patient is obese, he is hypertensive, elderly, and he has atrial fibrillation. You have already 6 points plus. So you don't need anything else to do in case patient is dyspneic. You have a high probability of this patient having heart failure with preserved ejection fraction, just based on this clinical data. But if you want to do an advanced work, then these are the criteria. The previous one was validated. This is still not validated with the wedge pressures and RV cath. Now you take functional, morphological features. You take biomarkers, that is anti-proBNP, and then based on this, you give points to this major criteria, 2 points for one major criteria, 1 for a minor criteria. So if you add up this, and if this is more than 5, you say this is a high probability. So what I wanted to tell you, you can only tell the probabilities. You cannot actually be very sure about heart failure with preserved ejection fraction. Why so? Because it is just half the truth. Once you've done whatever we've done till now, is just half the truth, because we have taken parameters at rest. What happens is that you have normal filling patterns at the rest, but the filling pattern may not be normal during exercise, and patient gets breathless on exercise. So I think that needs to be done. Let us say if you have a diastolic dysfunction documented on the echo, that what I would call it as a pre-clinical diastolic heart failure or preserved ejection fraction, because otherwise the patient does not have features of heart failure at this junction. Then a stage comes when there is an increased in LVEDP, there is a heart failure, preserved ejection fraction during exercise, and it normalizes at rest. So if you do tests at the rest, you would not be able to pick up this category of patients, those who are dyspneic on exertion. And then the stage comes when, even at rest, there are elevated pressure in the left ventricular and diastolic. Right? So that is the time when we actually detect. So we must make the person do an exercise to bring out the patients, those who are having dyspnea on exertion, on exercise. I'm giving you an example. That's a 62 years of male which has no history of CAD, but hypertensive diabetes is dyspnea class 2. So as this thing, we performed a stress echo, and the baseline echo shows A more than E, and E is more than 50. So now here the LA volumes were now normal, PA pressures were normal. So we did not make a diagnosis of heart failure with preserved ejection fraction on resting echo. We did a stress echo to rule out coronary artery disease as well as diastolic stress test. So just walked about 4 minutes, got dyspneic. We had to stop the test. It only achieved 71% of the predicted heart rate, and stress ECG was normal. But if you notice here, is E wave actually went up, and E prime generally remains the same. The E wave goes up, E prime did not increase, and landed up with E to E prime ratio being high. So if you have a E to E prime ratio which jumped to 16 after exercise, this is an indicator of having a diastolic dysfunction or heart failure with preserved ejection fraction. Now, average E to E prime, if it increases more than 14, the velocity across the tricuspid regurgitation increases, or septal velocity falls less than 7. These are the parameters which we take for heart failure with preserved ejection fraction during a diastolic stress test. Let's say if the patient is unable to do an exercise, what do? We do it in a semi-recumbent position first, and then we raise the legs. Okay, that's it, simple. Just raise the legs and keep it elevated for about 15-20 seconds. And once we elevate these legs passively to 45 degrees, transiently there is an increase in venous flow, causing an increase in preload by about 300 ml of blood, which is quite significant. And this actually brings out a latent or a hidden heart failure with preserved ejection fraction. And in case there are the parameters, diastolic parameters are abnormal on elevating the legs, then we say that this is a type of a diastolic stress test by passive leg raising. We would be missing a fairly good number of patients of heart failure with preserved ejection fraction. The reason is the problem may not be in the heart. Yes, that is true. Many a times heart is minimally involved, or this is overloaded, and this overload causes heart problem. So now we know that there are conditions where it can lead to heart failure with preserved ejection fraction without heart being grossly abnormal. So we might call it congestive failure with preserved ejection fraction rather than congestive heart failure. The heart may be okay. So it's put to as abnormal situation. Like now, heart failure with preserved ejection fraction has these kind of patterns. So the pattern one is that you have infiltrative disorders like amyloid, you have a left ventricular hypertrophy, you have a fibrosis in the left ventricle, and that causes thickening of the ventricle and the stiffening, right? But it may not be there in stage once you have a patient with increased volume. For example, if you have a patient with CKD, you have obesity, you have a liver disease, where the volume has increased. The same volume when goes into LV, the LV is mildly stiff, but with the increased volume, the LVEDP increases and the features of heart failure appear. So that's what the heart may be grossly okay and you have other systems causing it. And what are the precipitating, what are the other things which can lead to that? One is the fluid overload, a CKD, and obesity, which can lead on to heart failure with preserved ejection fraction, arterial stiffness when you have a stiff artery, the peripherally reflected this wave falls on the systole, and there is an increase in systolic load on the heart. And then you have inflammatory disorders like diabetes, obesity, the CAD. Now, they can also lead to heart failure with preserved ejection fraction. Now, there is something interesting here. Now, you can have an LA dysfunction and with a normal LVEDP can cause heart failure with preserved ejection fraction. Yes, rather than having an LV dysfunction, you have simply LA dysfunction which can cause heart failure. And that is why we took that atrial fibrillation as a very important factor in clinical parameters. Atrial fibrillation can lead to heart failure, preserved ejection fraction with normal or nearly normal left ventricle systolic and diastolic functions. So now second is an atrial cardiomyopathy, which is recently been recognized, particularly in amyloidosis, where it starts from the left atrium first. So it's just pure simple left atrial cardiomyopathy, which increases LA pressure. LA is unable to empty itself out into the left ventricle. And left ventricle otherwise is okay. And then you have a PA pressure, which can increase because of precapillary or pulmonary artery hypertension, or you can have an RV dysfunction because of multiple reasons, and you have features of congestion and heart failure, but you have preserved ejection fraction. So these are the categories. Obesity is something very special here. Now, obesity, you have heart failure, preserved ejection fraction. Obesity, there are a couple of things happening in obesity. One is that there is an increased afterload. There is an inflammation of the epicardial pad of fat. Fat is inflammation. So epicardial pad of fat, which is there right on the epicardium, it's supplied by coronary arteries and drained by the coronary veins. All that inflammatory substances actually interact with the myocardial cells and causes myocardial inflammation and causes heart failure, preserved ejection fraction. And this again is a fluid overload situation. Okay, so one interesting thing is that in obesity you have all other parameters, but anti-pro-BNP may be normal or mildly elevated, making it difficult to diagnose heart failure with preserved ejection fraction in obesity. So now we come to a point when there is a lot of confusion and you're still looking for more an association. And then what do? You call Mr. Artificial Intelligence. And what AI has done in heart failure with preserved ejection fraction, we've used many methods of AI. And in AI, what we found, there are some subtypes in heart failure with preserved ejection fraction. And these are three phenotypes, phenotype 1, 2, and 3, which we recognize. Phenotype 1 is obesity, where you have an epicardial pad of fat shown by an arrow, and then you have there is a low anti-pro-BNP. That's what I told you. So what increases BNP? Yes, neprilysin in RNA, neprilysin causes inhibition, that is sacubitril in RNA, causes increase in BNP. And this category of patients, sacubitril may be and valsartan combination might be a good way of treating these patients. Then you have inflammation, CKD, diabetes. Then the third is the pulmonary artery hypertension, which I told you, an RV dysfunction, which can lead to heart failure with preserved ejection fraction. The treatment on all three categories is slightly different. So what have we learned today? The carry home message is only a fool knows everything. We are still learning. So we are learning in heart failure with preserved ejection fraction yet. and we would continue to learn. And what we have learned till now is that you suspect heart failure and keep your index of suspicion high, ejection fraction normal, there is a patient with the dyspnea, you ruled out other causes. Please consider, do a stress, do whatever we want to do to prove that this is a patient with heart failure with preserved ejection fraction. And what we do to prove that is that we use clinical scores, we use NT-proBNP, we do a detailed echo and the resting diastolic parameter. In case normal, we still have a suspicion, we go ahead with the diastolic stress test, and then we use pulmonary wedge pressure and PA pressures on an invasive method in case still we have a very strong doubt of heart failure. Yes, we haven't learned enough. I have learned that I still have a lot to learn. Thank you very much for your kind attention. Please keep watching.